Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right, students, so I welcome one and all in the class tonight. And today we'll be discussing a very, very important and a very intriguing topic called liver disease in pregnancy. A little difficult topic, I would say, because the Viva goes into those spheres you're not really prepared with, as you'll see tonight. The case tonight is a little complicated case with a lot of comorbidities associated, and because of which I'll have to channel you again and again back to the topic of liver disease in pregnancy, because a lot of those comorbidities we've already discussed before. As I was just announcing that the case recordings for all these cases are available in your complete practical package for all the students who are looking for those classes which they've missed to attend live. Please go ahead and watch them on complete classes, complete practical course under the case discussion with students folder. All right, you'll be able to see. And today we have this liver disease in pregnancy being presented by one of my dear students, Shreya. And I welcome you, Shreya, and we can start with your case tonight.
Yes, ma'am. Thank you, ma'am. Can I start, ma'am?
Yeah, sure. Please start.
Presenting a case of Mrs. X, 31-year female, software engineer by occupation, studied till B.Tech, wife of Mr. X, 34 years male, software engineer by occupation, belonging to upper middle class by modified Kupuswamy classification. Was admitted on 25th of October 2023. Date of examination was also on 25th of October 2023. Obstetric score is Gravida 2, Abortion 1. Last menstrual period was on 3rd of April 2023 and expected date of delivery is 10th of January 2024. Gestational age is 29 weeks.
Okay, so like I always say, mention always beta with regular menstrual periods, making her expected. See, you will say last the LMB was so and so with regular menstrual cycles, making her expected date of delivery so and so, and current gestational age on the date of admission as 29 weeks. Always have a habit of saying this because it's in a flow. Your examiner understands that we are basing these calculations after asking her regular menstrual cycles. We did not miss this step. Okay, right now we've not taken the menstrual history, and over here we are calculating her expected date of delivery. We cannot presume that she was having regular cycles. There are many patients who come to us with erratic cycles, 2 to 3 months gap, and over here if we calculate it wrong, or suppose we did not, we missed to ask this question, we presume that it is exactly regular, then in that case unnecessary, the examiner is going to ask you, then you'll fumble, and then they'll say sorry. It's always good to say it in a flow. All right, remember that always. So she's 29 weeks. Yes. Why did she come to you?
Ma'am, she came with the complaint of pain abdomen since 2 days, and itching all over the body since 8 days.
So she had two problems, that she's having pain in abdomen and she's also having itching all over the body since 8 days. So one is acute, one is since almost 8 days now. Yeah.
Then history of present pregnancy.
Presenting complaints, huh?
Okay, ma'am.
Yeah.
History of presenting complaint. Patient gave history of 7 months of amenorrhea. Complaint of pain in lower abdomen since past 2 days, that is since 23rd of October 2023, which was gradual in onset, dull aching, intermittent in nature, associated with tightening of abdomen, non-radiating, with no relieving and aggravating factors for the pain. Fetal movements perceived, no complaint of bleeding PV, leaking PV. She complained of itching since 8 days. Itching started in the palms and soles and was extended to legs and chest area and ultimately started all over the body. Itching was more severe in the night, leading to sleep disturbance. Itching did not subside even after applying topical cream and moisturizer. Itching not associated with rash or eruption in the body.
Okay. You finish this, then I'll ask you.
Yes, ma'am. Next. Patient observed that urine was deep yellow in color since 7 to 8 days. No history of fever, loss of appetite, nausea, vomiting. No history of decreased fetal movements. No history of bleeding PV, leaking PV, white discharge per vaginum. No urinary symptoms. No history of exposure to insect bite or allergy to drugs.
Okay. Guys, now she already knows the answer. She knows how to prepare for the DD. I'll ask my students who are there in the class right now, what do you think, seeing this history over here. She's been very categorical about telling you certain signs and symptoms about the kind of itching that she's having. She's told you that it's not associated with any rash or eruptions in the body. Can you quickly tell me the DD that's coming into your mind? Do not just focus on one thing. Give me a DD, a differential diagnosis. Then we'll narrow it down. All right. So everybody who's there right now in the class, please start writing down why and what do you think this particular itching is. She's having it at 29 weeks of gestation. Itching is started in palms and soles and extended to the legs and chest, and then on the entire body. Itching is more severe in the night. She's having sleep problems. It's not subsiding even after applying topical emollients. And now and one thing very important, it's not associated with any rash or eruption. Though okay, that's one DD, fine. Now she's also having urine which is now deep yellow in color. We'll talk about your answers. You just keep writing down what you think it is, okay? I understand. See, why am I not quizzing her a lot about this particular pain? Because it looks like a pain which is going in the favor of either a Braxton Hicks contractions or maybe a threatened preterm, but it's definitely not associated with any other signs and symptoms, no bladder and bowel movement. Shreya, have we spoken about no bowel and bladder upset over here?
No, ma'am, not here, ma'am.
Okay, so yeah, this is important over here because the pain over here should be first and very important when any pain is there in the abdomen. No bowel and bladder upset associated, okay? So that thing we can handle, right? So anyways, we're not concerned right now so much on the pain. I'm talking about the dermatoses right now. I want to know what do you think is a DD? So a lot of answers are coming in, all right. So now you all feel has got something to do with the liver disorder, but nobody's talking about any dermatosis. Has anybody heard about the different kind of skin problems that can happen in pregnancy? So I'm taking you directly to that slide so that you people
26
know.
number, ma'am.
Yeah, thank you so much. So these are the different dermatoses that can take place in pregnancy, and we will now discuss from here. So Shreya, according to your patient in the kind of complaints that she's having, what would be your DD coming into your mind, and what all are the dermatoses of pregnancy, and why not the other ones? Points in favor and against the other dermatoses. Describe your DD.
Ma'am, in our patient, as we can see, itching is started from the palms and soles, and then it became generalized, and it was not associated with any excoriation. So DD of my patient came into my mind will be two: pruritus gravidarum and IHCP, intrahepatic cholestasis of pregnancy. Ruling out other causes, there's first is atopic eruptions of pregnancy. In atopic eruptions of pregnancy, we'll see it is more on the extensor surface associated with eruptions. And in my patient, there was no eruptions, ma'am.
No eruptions, yes.
And then, ma'am, second is the polymorphic eruptions of pregnancy, also known as PUP, puritic urticarial plaques and papules of pregnancy. It is more in the periumbilical region. It is mainly in the abdominal region and sparing the periumbilical region with eruptions, with erythematous papules. And in our patient, we didn't see anything like that. And also pemphigoid gestationalis, which is characteristic, has a bulle formation.
Yeah, absolutely. So are you seeing what she's trying to tell you guys? She's very categorical in telling you that there were no eruptions, there was no rash. Usually with all these, why have I brought these 4 dermatoses of pregnancy? Because they are the most common dermatoses of pregnancy, which is there. The other one is called pruritus gravidarum. We can't exactly call it dermatosis because there is nothing involved in the skin. All you feel is itching in the pregnancy. That's all there is. All right. Now that is a little difficult to kind of differentiate from cholestasis of pregnancy, unless and until, of course, you've done those liver function tests and they come out to be deranged, the bile acids are raised. Until unless that is there are some patients who just have itching all over the body just because of rise in progesterone level. It happens, all right? But you cannot, call it cholestasis of pregnancy until and unless you have bile acids raised. That's one thing. These 4 are the most common dermatoses of pregnancy, but it's none of them. Why? Because first of all, there are no eruptions. There is no rash. So until unless you have those eruptions, you will not call it atopic eruption or polymorphic eruption or pemphigoid. Pemphigoid is very categorical. See, over here you have, this is pemphigoid gestationis. See, these bullies are there and they involve the umbilical area as well. This is atopic eruption of pregnancy. You must have seen in many patients. This is a very common thing. But the problem with atopic eruption in pregnancy is usually you will find it in the exposed extensor surfaces of the body. You will not find it most probably on the abdomen or in the inner side of thighs. You won't see this, right? Then you come down to this polymorphic eruption. See, these are also eruptions. See, these are, you know, white lesions. They're kind of rosaceous or erythematous, papules, plaques, eruptions. So these are all raised surfaces. And this is how your cholestasis looks like. It's more like black spots. And you can have excoriations even with IHCP if you are scratching a little too much on the skin. So the skin becomes rough and excoriation marks will be there only because you're scratching, not because of the dermatosis per se. All right. This is what your IHCP lesions will look like. There will be no eruptions. Okay. There will be no plaques, pules, nothing like that. You'll just have maybe, you know, the scar marks because of itching, or these specific, what do I call them? Just these blackish marks on the body, but not the eruptions, nothing that the skin is, you know, erupting. So the other differential diagnosis will be pruritus gravidarum, and of course that we're going to only know once we get the reports, or we go further in this case. So this is what I wanted to finish off over here. So this is about the dermatoses, and why am I asking you right at the very onset is that because we spoke about the itching, and we are kind of narrowing our case down to cholestasis or pruritus gravidarum, and we wanted to specify over here that since the urine was deep yellow in color, it's going in favor of probably some liver cause. So again, in favor of cholestasis more. And why do we need to speak about all these things is that because obviously leaking bleeding we have to speak because she's having pain in abdomen, no decreased fetal movements, you have to speak, no fever, loss of appetite is kind of going against a liver disorder. She's not having any problem, but see, every time there is an advanced problem with liver, then the nausea, vomiting, loss of appetite starts. Early on, little derangement, it doesn't happen that much. All right. And she's not having any drug allergies. It's not one of those drug dermatoses, and there was no such allergic reaction because of an insect bite or something. Otherwise, that would have been more focal and localized. All right. So yeah, I'd like to ask you now, Shreya, is there anything specific you want to say about the first trimester, your patient?
Ma'am, first trimester was uneventful. Just she had a history of hyperemesis gravidarum at 9 weeks, for which she was admitted in the hospital and taken treatment.
And then she got, that got resolved spontaneously after treatment in the hospital?
Yes, ma'am.
How long was she hospitalized that time?
Ma'am, just 1.5 days.
That means it was not all that bad. So, guys, since we've already covered the case on hyperemesis gravidarum, a lot of discussion was there. We spoke about everything. We spoke about mild, moderate, and severe kind of nausea, vomiting, going on to hyperemesis per se proper, and hyperemesis we say when there is also weight loss, dehydration, and electrolyte imbalance, which obviously will only tell you the definition of hyperemesis gravidarum. Until unless it's that, you just call it nausea and vomiting of pregnancy. Okay, so she had a history. At that time, I'm sure LFTs were done. Shreya?
Yes, ma'am. Yes, ma'am.
So, is that important for our case? Why am I asking you this? Whether LFTs were done, whether they were normal? Why am I interested in that?
Ma'am, that from the starting, is she is having any dearranged liver function test?
Yes, absolutely. Now she's having urine yellow. Okay, so I'm kind of alarmed that my God, she was having some inherent liver derangement already. The liver was not functioning fine, perhaps. And another reason now to believe that she was having nausea, vomiting to that extent that she needed admission. At that time, I'm sure liver function profile was done. And if that time it was okay, I'm still breathing a sigh of relief that I didn't overlook a very grueling, intriguing sign which was right there before my eyes, and now I'm catching it when she's already having problems. So yes, it's very important for me. I can go on for hyperemesis gravidarum, but that's not a focus right now. Our focus is on something else, and we'll talk about it later on. So hyperemesis she had, that means there was a hint at liver derangement perhaps, and we have to think about on those grounds as well. Maybe from there we can take up the case further. So there was some inherent liver problem to start with. All right. Anything specific apart from this in first trimester?
Ma'am, also she was prescribed tablet Ecosprin 150 mg based on the scan report, ma'am.
So all my students who are sitting and talking and thinking and discussing this case with me, please tell me what all things can happen in the first trimester ultrasound scan that she'll be started on Ecosprin. What do you think are the reasons for us to start her on Ecosprin in the first trimester ultrasound scan, I'm not talking about the second trimester. That's very much obvious. Shreya, I'll clarify this thing to you in a couple of minutes. Let my students answer, and then I'll tell you what is the answer for your uterine artery Doppler. Okay. Yes, guys. Yeah, tell me please, why am I concerned about EcoSprint? What do I think has happened? First of all, tell me, guys, the gestational age at which placenta is completely formed. Tell me that. And some of you are writing down uterine artery Doppler. Has it anything to do with placental formation, or uterine artery Doppler is absolutely separate from that? What are we trying to see with uterine artery Doppler? Now, the question that I've asked you is that when is the placental formation complete? So the answer is around 16 weeks, 16 to 18 weeks, the placental formation is complete. Okay. Placenta takes over as a hormonal organ from corpus luteum at 12 weeks, but the placental formation is complete at 16 to 18 weeks. Before that, there is no sense of doing umbilical artery Doppler. All right. So whenever we start doing umbilical artery Dopplers are at 26, 28 weeks, and maybe at the earliest 24 weeks, but not before that. But uterine artery Doppler is the artery Doppler that you do at, that is telling you the flow to the uterus. Still, guys, let me tell you, the earliest of doing uterine artery Doppler is around 16 to 20 weeks. At the earliest 16 weeks. You can maximum see a uterine artery Doppler notching at around 12 to 14 weeks. That also, I mean, my institute is not doing. A couple of institutes are doing, like Shreya's institute. I think from there you will start seeing the notching, and then you brand them as high-risk cases, and you start giving them EcoSprint. That's a justifiable approach, because this is one of those, in certain institutes, the markers for high risk of FGR. We remember doing those high risk factors for FGR. One of them was PAPE less than 0.4 moms, and probably what I am expecting is that one of those results had come, because of which there is a recommendation of starting high dose EcoSprint. So unless and until it was PAPE less than 0.4 moms, I am not anticipating anything else would be so powerful enough for us to start her on EcoSprint 150 high dose. All right, guys. So I understand your answers, and I have clarified certain things to you. Okay, so just remember that uterine artery Doppler, yes, it's taken up very early, but in that case, your notching is seen, and you do not really go in for pulsatility index, because at that time, I do not know what are the, reference norms at that early gestational age. Mostly, they start around 16 to 20 weeks of gestation. All right.